Good morning. Thank you for inviting me. I hope to share with you our experience in Haiti dealing with disasters. Idyllic Caribbean, in fact, is affected by hurricanes. We are at the end of the hurricane season that should end in November of this month. Earthquake and even volcanoes. If one look at a typical year, which is 2008, you'll see that the region has been affected by 8 hurricanes, including 4 Category 4 hurricanes. Haiti, unfortunately, was hit very hard by 4 successive hurricanes that occurred over a 1-month period. Earthquake as well, because you can see that there are 2 major faults, one that starts in the Trinidad Tobago area that goes north of Hispaniola and north of Cuba, and another one that goes south of Puerto Rico to the Dominican Republic, hits the capital of Haiti, Port-au-Prince, and the capital of Jamaica, Kingston. In fact, we know that earthquake will occur. What we don't know is when. Haiti has been the most fragile country in the region for the past 30 years. The GNP has been unchanged while the population increased by 60%. 80% of the college graduates live abroad. And migration is directly linked to political instability and natural disasters. Since 1986, we've had 22 governments, hurricanes, earthquake, and now 2 major epidemics, AIDS and recently cholera. I'm showing you, this past year, we've had first the earthquake on January 2010 that caused over 220,000 deaths, 1.5 million internally displaced people. The country lost 20% of the 2009 GDP. Most hospitals and schools were destroyed, particularly in the West Department. That created a huge stress on the healthcare workers. And then 9 months later, as the country was starting to recover, totally unexpected and unrelated, we have the cholera epidemic, which is the first occurring in a country totally naive to cholera, but in a population where 70% of people do not have potable water and sanitation. But the population is infected by a host of other diseases. Then 1 month after the cholera epidemic, we have Hurricane Thomas that caused much flooding, that's increasing the cholera cases. And one what I call the political tsunami, the November elections, that caused the same month political unrest in the second city of Haiti. The following month, major unrest. The country really stopped for about 10 days. In May of this year, we got a president, but it took him about 5 months to get a government. Now, this is our institution, GHESKIO, created in 1982 with a mission of research, service, training in HIV, AIDS, and associated diseases. We partner with the Ministry of Health from day one. In fact, the Minister of Health was a co-founder of GHESKIO. And also we partner with 116 local institutions. We are granted the status of utilité publique for institutions deemed necessary for the welfare of the Haitian people. We've had continuous support from the NIH since 1983 and the Fogarty since 1988. A very strong international collaboration. The arrow shows the downtown site of GHESKIO, one of our sites, which is located across 2 major slums, called ironically City of God and City of Eternity. And you also see the map of the UN forces. So you see we are right in the middle of the hurricane, the area where they say one should not travel. And we also have a second GHESKIO site, which was opened in 2009. This is the Warren D. Johnson Medical Center and the Laboratoire Rodolphe Mérieux with BSL-3 facilities. You see here Andrew Schaeffer, Chairman of Medicine at Cornell, Warren Johnson, Head of Global Health, and Alain Mérieux from Fondation Mérieux. Now, this is the situation, a brief summary of the epidemic. From 1982 to 1990, we've developed integrated HIV model of prevention and care, both in urban and rural areas. From 1991 to 2002, we're implementing and the scale-up of that model. And with Global Fund and PEPFAR support from 2003, we were extending the scale-up of ERT. You can see GHESKIO has 28 centers, most of them in the West Department that has been the most affected by the earthquake, and the HIV prevalence that has been coming down from 6.2% to 2.2%. Came the earthquake, and the arrow shows the darkest areas that have been the most affected. You can see our downtown site, and you can also see the GHESKIO neighborhood totally destroyed. So the impact on us was huge. We lost 4 staff members, including the head of our microbiology lab. 44 staff, among the best, left the country. 20% lost one parent. 70% had their home damaged or destroyed. We lost 75% of our workspace capacity at our downtown site and 50% at the recently built new site. So you can see here all our walls collapsed. So what happened is that the population from the slum just came on our campus. So what has been our response to, first, our normal mission of HIV care research and training, and then 3 additional tasks that we had to take. First, we had to set up an acute care hospital because people were coming with the worst wounds, and we are not equipped for that. So we are fortunate that we are able to team up with the US Human Health Services to offer this kind of facility. And then a TB field hospital, because our hospital collapsed, and we also had to provide TB diagnosis capacity. And perhaps the most challenging was the fact that we had over 7,000 people who were on our campus and needed complete support. So our response was first to stop enrollment in all research projects and to stop all training, concentrate on patient care and retention, making sure that HIV-infected and TB patients had enough meds. We have a practice of providing 2 weeks of extra critical drugs to our patients, thinking always that problems in Haiti will rarely last more than a week. We activated our contingency plan for tracking patients, 24-hour on-call phone lines, phone cards, correspondence, very important. This is a person that serves as the link between the patient, the volunteer, and our institution. Radio message and depot of drugs at some of our staff to make sure that it's widely spread so that in case there is a transportation problem, our patients could get it. The result is that 4 weeks later, 94% of our patients were accounted for in taking their medicine, and the 2% were accounted for in one of our other affiliated sites and taking their meds, and 211 were confirmed dead. So you could see here in blue is the total number of people on antiretrovirals in Haiti, and in red, this is our network in collaboration with the Ministry of Health. You can see that we represent over half of all people on ERT in Haiti, and you also see the retention in care post-earthquake that has been fairly good. Now, we had to have our clinic outdoors because of the aftershocks. People were scared to stay in buildings, even though they were secured, so our pharmacy was also outdoor. This slide here depicts monthly enrollment on ERT in 2009, before the earthquake, in blue, 2010, during the year of the earthquake, and 2011 in green. You can see that except for January of 2010, when we had the earthquake, we've been picking up the enrollment on ERT, and this year we should be doing much better with 271 patients on the average being placed on ERT. Our aim is 500. Now, let's focus on NIH research protocols. January 12, that's the earthquake. 1 year later, you can see that we've enrolled in HIV vaccine trials over 100 patients, and at present we have 1 trial that's completed and 3 trials ongoing. For ECTG, we've enrolled 200 more patients since the earthquake, and we have 3 trials completed. The CIPRA study, I'll be telling you more about that. The reason why you see less patients being followed is because some have died of AIDS and 16 died during the quake. We are part of a new network, Impact. So all in all, we have enrolled over 300 patients since the earthquake, and we are the lead institution in 3 ongoing protocols, 2 ACTG and 1 HVTN. For this HVTN 907 study, which aims to enroll commercial sex workers, our incidence rate at present is 2%, which is quite high. Now, a little bit about the CIPRA study. This is an NIH-sponsored study aimed at determining when is the best time to start antiretroviral therapy. Should it be started at the then WHO recommendation less than 200 or at 350? And you can see that the Data Safety Monitoring Board, after we enrolled 408 volunteers were comparable in each group, stopped the study because there were 4 times more death in a group that started late and 2 times more TB. So everybody was placed on antiretroviral therapy at that time. So this slide here shows you what happened in terms of TB status of people, everybody on ART, and you can see that from 21 months to 45 months, those who started late continue to having a much higher rate of tuberculosis. So essentially, patients who delay initiation of ART have an increased incidence of TB even after ART start compared with patients who receive early therapy. Now, in terms of training, we are the largest training center. We've done pretty well also. That's what started the latest. We resumed training 4 months after the earthquake. But we also resumed 3 specialized training, the first MPH program that we've put in place. And I'd like to thank collaborators like Peter and others who have contributed to this program. We've started a nurse practitioner program and also a laboratory training program in collaboration with the Ministry of Health. Now, what about the other responsibilities that we had? Essentially, we had to put up an acute field hospital, and then 1 month later, create something totally new, which is a rehab center now that follows 3,000 patients on rehab. You can see at the bottom our MDR-TB hospital before the earthquake, after the earthquake, and what it is now. We have patients on tents. We've seen an increase in tuberculosis, and some of us will be presenting that at this meeting. I'm focusing here on the pediatrics and adolescents. You can see in blue, 2009, and that increase has continued for pediatrics and also for adolescents. What's interesting is that 2/3 of the kids are less than 2 years old, 60% are HIV negative. TB workload has been huge, as you can see, for TB screening. We went from 18,000 in 2009 to 30,000 up to this October. We'll reach 35,000 before the end of the year. Much increase in TB cultures and also in rapid testing. And we are detecting, obviously, many more cases of MDR tuberculosis. Now, the most challenging was the Global Health Program for internally displaced people. They came on our campus. We put them in another place that was well prepared in advance. And we've been able to offer water on day 1, set a committee to run the camp, daily evaluation of patients with fever, cough, diarrhea, and rash. That's how we diagnose many cases of TB. Immunization of children and pregnant women and prenatal care. We practically have no deaths. That's by doing those very simple things. Prevention of gender violence. We have no more gender violence, and some of it will be presented at this meeting. We created a vocational school with support of the Clinton Bush Haiti Fund, and there we've graduated 500 people in construction work. And we have a primary school for 300 kids, and there's a school being built right now that will be completed by March of 2012. Now came the cholera epidemic, as I said, totally unexpected. This is a slide that I borrowed from Scott Dowell at CDC, aimed at comparing the impact of recent cholera outbreaks of the countries most affected from 1991 to the present. And you can see that Peru led the way until Haiti came. And we are looking at Haiti at really 44 weeks of the outbreak, 4 times more cases than Peru. In fact, 1 year later, we have over 476,000 cases and over 6,600 deaths. The fear of cholera was huge. The medical staff was wearing a mask at all times. When patients started dying, they said they would rather have AIDS than have cholera. People stopped shaking hands even at church. Even some hospitals refused to admit patients, and funeral parlors also refused to accept people they felt could have died of cholera. So fortunately, our life goes full circle. When I came back to Haiti in 1980, My work was essentially in infantile diarrhea. And this slide shows you, by introducing oral rehydration and careful monitoring of patients, we're able to bring the mortality down from over 40% to less than 1%. And within 2 years, a national program was created. 16,000 health workers were trained, and the mortality, infantile mortality, dropped by half. What's interesting on the right also is a national survey that was done in 2005, much before cholera came in, and shows you that mothers were using oral rehydration therapy, and up to 70% of those who are well educated. So what we did essentially was to set up 4 cholera treatment centers. Those are large units with over 100 beds, 4 cholera treatment units, and 24 oral rehydration points. We had to train personnel in the 1,000, and we developed a model of prevention and care intensity, slums, and markets. So over a 1-year period, we've seen over 12,000 cases, about 1,000 per month. Here, it's a typical oral rehydration point that we put in a slum. So people get orally rehydrated, and if they do well, they go home. If not, they are referred to our cholera treatment centers that you see here. It was very, very difficult in November and December when we had the political problems, because all the streets were blocked and patients had to come on motorcycle, and even we used motorcycle to have our staff get water and food. This slide depicts at our 2 cholera treatment centers, we've seen 7,444 deaths, 44 patients, 18 deaths. And what's interesting is that 6 of those deaths were in people who were HIV infected. What's interesting also is the fact that in May, June, our peak was higher than in the early phase of November and December. And now we look like we are going to see another peak. So essentially, rehydration is key, IV or oral, antibiotics for anyone who is admitted, vitamin and zinc for kids, start or continue oral rehydration therapy. Think of other diseases. People, it's a sick population. They have TB, they have many other problems. So if they remain febrile, cholera doesn't give fever. They remain febrile after you know you got a problem. And you need to discharge them when they can drink and their stool volume is reduced. So essentially, what does not kill you, that's a peasant Haitian proverb, can make you stronger. The Caribbean is at risk for natural disasters and major epidemics. Our long journey has gone full circle from infantile diarrhea to AIDS to now global health and cholera. The tripod of research, training, and care gives a wide support base. Research provides the capacity to develop local solutions to local problems. Training makes it possible to identify, train, and retain the very best, to have a reserve pool to replace missing or lost staff during the time of crisis, and also the possibility to scale up nationwide successful research results. Strong partnership with the Ministry of Health is essential, as well as with local institutions. We need to build community trust with a very strong community advisory board and very strong work ethics. Leadership is essential. We need to plan ahead at all times. After each disaster, see how you can do things better. Haiti has the opportunity to build better and to provide potable water and sanitation. Management capacity is essential. One always need to have one backup for each key position. Contingency plan must always be in place with different codes according to level of emergency. And most importantly, as we are not eternal, we need to always create a new generation of dedicated staff to carry on the work. I'm sure you'll be seeing many of them during this meeting. I'd like to acknowledge many people and institutions, NIAID for HIV research support before and during